If it allows me to move forward. There we go. So today's objectives is I want to throw out some terms that are really important in development. Straw is one of them. It's one of the biggest studies done for reproductive age, and it's based on a workshop that was done across the United States. And this is really from birth to menopause, and that's where we're going to really talk about the journey of our eggs. Because believe it or not, for the women in this audience, you have the most number of eggs when you are 20 weeks gestation. So when you are in utero, you've tapped out. It's just downhill from there. Just kidding. All right. Understand ways to maximize your health preconception, because that's a time frame in our decades that we want to be healthy. We want to prepare ourselves and our patients. So even for those of you that don't directly interact with women's health in your day to day, it does translate in the future. And then, of course, what are the screening guidelines across the spectrum of life, especially for those that you have nieces, nephews, children, and when and where should you take them? So I just want to really bring up that we here have Cats Women's Hospital. So the Women's Hospital in the truer sense is an inpatient bricks and mortar that take care of not just obstetrical needs, but those that are related to gynecologic care, breast health, and so forth. So we really want to redefine that in terms of what we should be looking to strive to be. The other piece is that the CATS Institute for Women's Health is a separate but connected entity that is looking not just at OB and GYN, but how does the cardiac, how does the surgical play into all these phases of a woman's life? It has research. There was a recent meeting this week about research grants. So if there are things that you guys want to do or you're interested in doing, we should be applying for grants together. There's grant funding, there's programming, there's webinars, there's community events. So when you're out and you think, wow, wouldn't this be a cool thing to do? That's how seed money gets started and given, and bigger projects come from it. One of the biggest things is endometriosis, which started from a seed grant from the CATS Institute. So again, the Institute is about research, community collaboration, and physician nursing ACP connectivity. Why does it matter? And I know this probably doesn't surprise you. Men have been the default in medicine. So women were untreated, undiagnosed, and the research is not present. So that way, a symptom for somebody who does have a biologic female with two X chromosomes may not present exactly the same way as their counterpart. And I think also in the time of transgender care, of how hormones and people's symptoms may be evolving, really important to be very broad in terms of what we do. And as many of you know, the household is usually 80% are made decisions from the chief medical officer in the house, which oftentimes is mom, grandma, aunt. So to understand that we often as women put ourselves last is a really big thing that we need to change. So again, like I said, there are ambulatory sites, and what you're going to start to see is more, we call it bricks and mortar, more offices that are going to be labeled CATS Institute. There will be a very exciting launch come early next year, which I'm excited to share will be related specifically 100% to women's health, pelvic floor conditions, vulvar pain, breast surgery, things that we know are so important. I see people shaking their heads. Could you imagine? No, this is great. Could you imagine going to a site and seeing your GYN surgeon, your colorectal doctor, a vulvar pain specialist, and get a breast check? Game changing. And maybe a little bit overdue, but we're going to get there. The work that the Institute does, again, is about continuing medical education. So though this lecture series is not specifically supported, experts like myself want to come and share that knowledge. It's all about collaboration. Patient experience, instead of saying yes, no, how about what do you need? How can I help you? Those terms make a big difference. Do you understand? Yes or no? Well, everybody says yes. Yes, I understand. Can you tell me back what I just told you? No. Okay, let's start again. It's about that listening, truly listening, community outreach, and things that I mentioned. We also, if you guys are interested, have KIWH ambassadors. So if you want to be an ambassador for women's health, sharing information and being part of our community, or if you want to receive our women's circle, you just let me know because that's another opportunity comes to your phone, at least with a circle for updates. And you'll have this. Okay. That's the women's health part, which is, again, understanding in this big organization what's out there. So that's kind of a level set for everybody across our team members here and those in the virtual world. Okay. So we talk about women's health, but where does it start? Like I said, it starts in utero. So 6 to 7 million eggs when you are 20 weeks gestation. So your fetal age, you tap out. You see MFM, maternal fetal medicine, they scan you, they say everything looks great, and then you're born and you've lost millions of eggs. Doesn't bode very well, right? So where do they go? There's a whole process of apoptosis or apoptosis, depending on potato, where your body has these chemical triggers if you do not have the SRY gene and it goes away. And the same process that when somebody does ovulate, the eggs are triggered, they're matured, and they release. And if there's not a conception, they just involute and go away. So they float into space. So sometimes people ask that, well, I don't have a tube anymore. If you've had tubal surgery, where does it go? Just like magic, like magic. When our daughters, nieces, grandchildren get to puberty, they're down to 300,000. I know these seem very bleak, but all you need is a couple, not even a baker's dozen. So again, I think I'm a visual learner, and for those that I have the privilege of working with, our field is very visual. We're looking at tracings, we're looking at monitors, we're looking. So this graph to me is so powerful that the optimal fertility is 18 to 31. And I want to put that in an asterisk with quotes because this is where egg preservation and future thinking is really important. So we're not mandating that people freeze it, but what I think is necessary is to have conversations with patients, again, no matter where you live in the medical world, to think that if it's something that you want to do, I am not going to be naive in the sense that it's not cheap, but that's something to kind of consider in the future. And I will give a shout out to Northwell because our insurance is extremely kind and they cover a lot of fertility and egg preservation. I swear I wasn't paid to say that. We talk about this magical number 35, advanced maternal age. Nothing makes me cringe more than that terminology, as I had children at advanced maternal age. I like to say it's your vintage pregnancy or your Gucci age. Dior, perhaps. But many of the numbers started around 35 because that's where the decline starts in terms of egg quantity, and there also is an aspect of quality. So 35 came about with some testing and genetic risk. So as amniocentesis, which is a very thin needle that goes through the uterus to sample the amniotic fluid, that risk of a miscarriage loss was around the same as a genetic risk when the process started. So that's where the 35 came about. And then 35 is where you start to see a more significant decline. And for those of us approaching that last bullet point, you don't really have much left. So we want to talk about the egg, right? So you've had what you're going to be at puberty, and this is the stages of puberty. And we do at Northwell have 2 pediatric adolescent gynecologists that specifically will deal with any issues that come from younger children. So I think that's a really important thing to share. But this is the general change of what's happening in a female body, all triggered by our eggs, by the hormonal connection between hypothalamus to the pituitary, to the ovaries, then to the uterus. Average age of the first period, usually you'll grow about another 1 to 2 inches, depending, and that will vary also where things like obesity or other comorbidities have been driving the age of puberty down. So again, really the whole spectrum of where we need to care for people's lives also starts for us, right? The chief medical officer, what kind of snacks do you have in the house? What are you doing? And please do not think that I'm judging anybody's food pantry. I wouldn't let any of you come into my house and see what I have, but I think it's about making good choices at least more than 50% of the time. The term to come up also is Tanner. So these are the stages of development. Again, things to start thinking about, and these are average ages. So if you feel that something is not fitting right with your family member, your person that lives in your house, definitely talk to your pediatrician and just confirm. And like I said, this is how it is happening for females and males. And now I'm kind of bringing you all back to nursing school and all those fantastic graphs and charts that everybody learned. But essentially, there is a negative feedback loop that helps drive from the hypothalamus to the pituitary, triggering LH and FSH, and then leading to estrogen and progesterone. All right, so adolescence. So, what is happening? So you can see this is my beautiful daughter. I love her more than anything. She was delivered at the Cats Hospital upstairs, room 6. So thank you all, our fantastic nurses, and especially my nurses in the audience right now, which I didn't plan. um, so sometimes she'll be really happy. Sometimes she'll be really inquisitive. Sometimes she'll want to throw a dagger at my head. This is normal. It may be very challenging for you as a parent because they were adorable little 7-year-olds that you wanted to like mush in your face and they were so sweet. And now you have to channel more energy and more patience. This is normal. And again, I keep saying normal because what will happen on the back end of our reproductive health life is we're going to have these ups and downs where we feel really good, we feel really bad, we feel really good, we feel really bad. This is what is happening. There are interventions. I find timeout is very effective for this age time, or at least if she listens. She's my daughter, so she doesn't. Okay, so what is happening with the cycle? You will notice the changes, and I like the bottom, the uterine cycle. So right after a period, the uterine lining is the thinnest, and then everything starts to trigger up. Hypothalamus to pituitary to ovary. That's our circle, the HPO circuit. And you'll see at the very top, you have the egg development, and the follicle is so small. So when you think about what reproductive endocrinologists are extracting, it's just remarkable what they do. And in a standard ovulation, you have a mature follicle, the egg pops out, will dissolve on its own if it's not fertilized, and then that remaining piece, that corpus luteum, will involute and go away. Luteinizing hormone, follicle stimulating hormone will peak, and that's all the almost bottom graph where estrogen triggers this. So an estrogen surge triggers LH, FSH, and then the back end, that progesterone in the middle, the ovarian hormones. Progesterone protects the uterus. So if somebody were to get pregnant, it helps stabilize the lining. When you are not pregnant, the uterine lining will shed. This is without any hormonal intervention, and progesterone makes you feel bloated, makes you want carbs, makes you more tired. So the best thing to do if you are cycling or know somebody that's cycling close to you, more hydration, more protein, it makes a huge difference. Although your body wants Twix bars. It does. My body wants some right now. In terms of vaccines for adolescents, Gardasil, it used to be a shot of 4, now it's a shot of 9. Gardasil for, I write persons because it should be for boys and girls, 9 through 14, and it can be given in doses depending on if you do 2 or 3 and how it's spaced out. Your pediatrician should be able to provide that for sons, daughters, nieces, nephews, etc. The 9 types of viruses, and listen, we've been through everybody in this room for all the work we did through the worst virus we've ever lived through. There are different strands of it. So that's what the Gardasil does is it has different variants of the human papilloma virus, HPV. And guess how many? 9. High-risk types that will protect men and women. All right, the feared Pap test. I know for us that are on the Northwell Insurance, our GYN Pap test counts to our health credits, so you want to get those done before the end of the year, just a ploy for that. But there really are specific guidelines based on risk assessment. Under the age of 21 today, they should never have a Pap, period. Between 21 and 29, the cytology, so just the cells alone, and you could see every 3 years, which for some people pains them. Again, this has to be a conversation in terms of comfort. If it's abnormal, not abnormal, if there's new risk factors, new partners, that will change what we need to do. 30 to 65, if you are doing co-testing, so you have a viral panel for HPV and cytology, which is the cells, you can space it out. Again, older thinking was that every year you go for your Pap test. But your women's health visit should not just be based on the PAP alone. It should be your screening, which we'll get into. It should be your conversation of how you're doing. Could you imagine, like, your mental health check? A PAP in it and of itself, and I'll have patients come in, well, why is my insurance not paying for it? And I will be the first person to fight any insurance for what my patients need. This is really based on good data and risk assessment. So if you do not have a new partner, your HPV risk is low, and if your PAPs have been normal for 10 years, after a certain point, you can defer having a PAP. Again, individualized, but if you hear those changes, it is based on good data. So for many of us in our teens and 20s, we talk about contraception. This I also love because what are the failure risks? There are many options. There's hormonal and non-hormonal. They're really, really well. And this is what I hand a lot of my adolescent patients, my patients that are in their 20s. What do you want to do to help protect you the most? Implant IUDs, and there's different types of IUDs. The IUD itself is literally about the size of an OK sign. It's really small. And the average uterus is the size of your fist. So it sits right inside, IUD, intrauterine device. Progesterone ones and copper, none of these IUDs, as opposed to every other single contraceptive with the exception of sterilization, affects ovulation cycles. Why does that matter? If somebody comes in and says, my mood is so bad for 2 weeks of the month, but I don't get a period because I have a Mirena, well, I'll say, well, of course, because your ovaries are still working. So again, just a different way to think about it. Every other contraceptive here will suppress ovulation, obviously, except the last column. That's not as effective. That will not suppress ovulation. I want to check time. So maybe baby will be for some people thinking about menstrual cycle and timing. So your most effective time for conception is when you ovulate, which makes sense. The egg will be viable for about a day. Sperm are viable for about 3 days. So we spend many of our days and nights trying not to get pregnant when truthfully it's a very small window in which you actually can conceive spontaneously. So if I'm counseling somebody about preconception, I'm going to say, get your baseline. What's your start to start? And then you work backwards because that second half of that cycle, remember when that progesterone went up, is pretty standard. That luteal post-ovulation progesterone surge, 14 days, pretty standard for most people. It's the beginning part that can vary. So 21 to 35 days from start to start is a normal cycle. And if there are variations with PCOS or other medications, these are variations. But in general, you're going to ovulate 2 weeks prior than the first day of your period. So Valentine's Day on a non-leap year is the perfect day to conceive, day 14. Is everybody busy on Valentine's Day? Okay. Preconception consultation. So you want to review medication. So if you're working, again, this is very OB heavy, but this, again, is the spectrum of life. You want to think about consultation. Do you need to see a reproductive fertility specialist? If you are under 35, a year to conceive is normal. If you are over 35, your window is smaller, right? Because that's when that curve starts to go down, and you want to maybe seek some help sooner than that. Obesity, other comorbidities, mental health, all really important. And the best thing you can do is start a prenatal vitamin that has 400 micrograms of folic acid at least 4 weeks before you try to conceive. The good thing is most of our breads, foods, cereals are all fortified with folic acid, so you should have everything you need. The one caveat is that if there is a family or personal history of a neural tube defect, you need more folic acid. Are you anemic? Do you have a thyroid issue, diabetes, immunizations, deficiencies, all things you want to do preconception, as well as a carrier screen, right? So we're talking about like the Punnett squares and what your risks are. We now can check over 400 genetic disorders from sickle cell to cystic fibrosis preconception. Because if your partner carries something, it's often better to know before you try to conceive than playing catch up. Again, the geriatric, advanced maternal age pregnancy, you do have higher risks. I mean, that's just fact. There's more genetic complications, pregnancy loss, higher risk of high blood pressure, diabetes, and preterm delivery. When women are older, the benefit is that most of us can be a little bit more secure in terms of ourselves, our financial status. So that's why a lot of us have delayed our childbearing, which is absolutely fine. You can still get pregnant. It's just a matter of trajectory and timing. So I have a lot of women that are on that early 30s, mid 30s that do egg preservation if they're not in a place in their life where they're ready or want to have a family. The pregnancy mythbusters, I love this. Caffeine causes infertility and miscarriage. I don't think I would have survived on the labor floor without caffeine pregnant. So this is absolutely false. And we do want to limit it, but not just because it's going to cause these other things, because your blood cell volume and your plasma volume go up in pregnancy, and your heart rate and the volume, everything changes. So your heart's going to race more, especially that's why we want to avoid excess caffeine, which is true in and outside of pregnancy. Birth control affects future fertility. False. You were born with a certain amount of eggs. Your egg lifespan is out of the control of contraception. Contraception just keeps those eggs that will naturally die at bay. This is a big TikTok myth. Heat is bad for sperm. That's actually true. No hot tub saunas before somebody would want to conceive. You also don't want to get in a hot tub sauna or jacuzzi if you are pregnant. And supplements, really, you've got to speak to a physician, a provider, a nurse about what they're taking. Most of them are probably not well studied, but fine. Do not stop psychiatric mental health medications on your own. So, for those of you that are working in any of these mental health sites, make sure the maternal fetal medicine, the obstetrician are involved, because many of these medications are safe. And there is a 1 in 7 chance that a woman in the postpartum period within the first year of delivery will commit suicide. That is a staggering statistic. Do not have them stop their medications without appropriate consults and following. So some fish do have higher mercury levels, so you want to be cautious. Pineapples, as much as I did try, do not put you into labor. They do not make you more fertile. They'll just cause incredible diarrhea no matter how much you eat. So do not eat as much. And the hair coloring, I've never seen there be an issue, nor will there ever be a study to do it. So, and highlights never touch your head. So if you want to highlight your hair, go ahead. All right, now you're home. Now you have a screaming human. You've gotten through your whole fertility, your egg worked, you're happy, but you're really not happy. How many people in the audience or in the virtual world have children? Okay, that's a lot. How many want children? That's a double hand in the back. How many don't want any more? That's a triple hands, quadruple. Oh, there's a shaking, maybe. So 60 to 80% of women, and we've not studied the male population, so that may be something that we should actually look for. So thinking about future things to look, will have baby blues. So in the first 2 weeks, you're going to have a significant hormonal drop. Everything revs up. You feel great during the second trimester, and then everything drops. It usually is very self-limited, and that's that 2-week mark. So if you know or see somebody that's suffering after that 2-week mark, there may be an issue. And what's also interesting is that we're not necessarily picking up our anxiety disorders, because it's not just postpartum depression, it's mood and an anxiety disorder. 11.5% of women giving birth will suffer from depression, and in certain communities, it's up to over 30%. That's a lot of people. So if we don't ask these questions, and I do applaud all of our nurses on our postpartum floors, every woman leaving here gets screened for postpartum depression and mood disorder. We know that those first couple of days, of course you haven't slept. Of course you're exhausted. But there are other warning signs that we're picking up, and that's so important in the ambulatory world and in the hospital that we are not missing patients. These are criteria. This is from the DSM-5. Just again, you need 5 of the following. Now, I don't expect any of us to be psychiatrists if we're not, or psychiatric nurses. This is just to be aware that you have to have a lot of things going on. And if a woman that you've come in contact with has it, you really need to help escalate that. And there are resources through Zucker's, there are resources through South Oaks, there are resources through the CATS Institute. They are there. You just need to ask the right people. So what should we be doing from an obstetrical standpoint is that we should be screening women in their early pregnancy, midway through the pregnancy, and then at least once postpartum, and probably need to do it more. For those women that you come in contact with at anywhere in your clinical life, these are the list of things that makes them higher risk for depression, and anxiety is one of them. We should be screening all of our patients for this. We also should be screening for domestic violence, which is on this list, as well as gun safety. These are all things that keep coming up in discussions, and we will work to make sure that all of our women will be screened at some point. Okay, my family is complete. So again, I want to reiterate, what are the effective contraceptive methods and the set it and forget it? So tubal ligation, we actually don't do tubal ligations, which are just cutting the tubes anymore. There's some literature, it was done in the GYN literature, that if you take a whole tube out, it actually may decrease a woman's risk of a GYN related cancer. We have to look more on the obstetrical population, but some of these ovarian cancers may not be ovarian in nature. They may actually be tubal. So if you're not going to use it, there really is no reason, and that does not increase any complications. Maybe it adds a few minutes extra operative time. Again, pills, I would not recommend the injection on that second row. Depo-Provera has concerns with long-term use for bone density. So again, if your family's complete, we tend to be moving to a different stage of our life, which is where we spend most of it in peri and menopause and menopause. So that may not be the best option for you. Okay, straw data. So we talked about tanners, we talked about egg count, when you have the most. Stages of reproductive aging workshop is the most comprehensive data, putting all the pieces together from birth to menopause. I want you to look just at that last line, the endocrine line. So that follicle hormone is triggered by estrogen and lets an egg get ready. In the adolescent stage, it's up and down until there's some more consistent cycling. In the end period, closer to perimenopause and menopause, it will be all over the place. So if a woman tells me, well, can you check my blood work and tell me when menopause is coming? I said, I can check your blood work, but I'm not going to tell you when menopause is coming because it's very erratic. So that mood in adolescence, the same thing happens because there's an up and down like the stock market crashing. It's very real. The stages of menopause, so perimenopause, there's a kind of a start and an end. When you're going more than 3 months between cycles, that's usually the beginning of the end. And it doesn't mean that it's the end at all. It's a matter of reevaluating what a woman's health needs are at that period in time. The first thing we typically see, and I also want to say it says postmenopause, I think we should just be saying menopausal because we say we have adolescence, well, we have menopause. It's not post anything. Your period stops. Whoop-de-doo. If you have a hysterectomy, the same thing would happen. We need to then really, again, address what women's needs are. I love this slide because it is so powerful. So 40% of women will go through menopause, 40%. Like, I mean, everybody will go through menopause, but right now they can live 40% of their life after their period. So that's a long time. Every woman will go through it, and most of your life will be in this period. There'll be 62 million women 50 years or older. That's what happened in the last few years. 6,000 women each day reach menopause. So the periods are stopping, and that could be from surgical, chemically induced, or just natural menopause. And there's a difference between surgical or chemical because there's a lead up time that your body is getting ready for. Again, that 3-month transition times takes longer. And then 10% of women will experience menopause before 45. A quick and dirty thing you can use is just these 6 questions. Northwell has supported through the Katz Institute the Menopause and Midlife Program, the Triple M I like to say, where we have 45 plus providers across our network that are going to be able to handle from medicine to cardiovascular to gynecologic and hormonal care for women. And these are the 6 basic questions that every woman, I believe, at age 40 should be asked by every GYN, every primary care. The biggest thing is, are your periods changing? That's the cycle. So your cycle, your eggs are not going to produce as much hormone. Cycles get closer together, then they space out, that accordion. And then when you hit that 3-month space, things start to change. Why are women having hot flashes? Because let's go back to that first slide, the hypothalamus. The hypothalamus desperately wants estrogen that your ovaries are releasing. So when your eggs are starting to rot, like mine are, the estrogen levels are less, and your brain is desperate for estrogen, and it's just not there. So that's what triggers a hot flash. It's a hypothalamic thermoregulation. Lack of estrogen can also increase issues with sexual concerns, pain, or dryness. And if I ask a patient, how is your sex life versus how is your sexuality, that's something totally different. Sexuality is how you feel, how you communicate with somebody. But if somebody says my vagina hurts and it's painful to have sex, you're not going to put your hand on a hot stove. It hurts. You're not going to do it. But we have to start addressing things in a more holistic way. The bladder is, as you all know, is very close to the vagina, so the pelvis itself is affected. And then if you're waking up every 5 minutes sweating, you are not sleeping well. This is a huge part of why there is $1.8 billion are lost on women's productivity at work on an annual basis in the United States because we're not getting the care that we need and deserve. That's a lot of money. And then, of course, mood. So these are, I just love these schematics, so you'll remember these. Hot flashes, headaches, irregular periods, insomnia, memory, painful periods, low libido, weight gain. Oh, weight gain. That's another big one. No pun intended. So my older eggs. So again, like we talked about, the purple line off to the left says, my left, your right, says it all. Up and down, up and down, up and down. There's a very brief change in that adolescent window in puberty, but it's very significant. And your temperature, tissue quality, fat distribution, like we said, the hot flashes, the vaginal dryness, that's the tissue component. And guess where fat is made? Fat is made in our belly because it makes estrogen. So a different type of estrogen our body's craving when we don't make it in our ovaries, and it goes right to the menobelly. I know but there are things we can do. We can increase our protein. We can build our lean muscle mass. Everybody needs some bands at their desk and their workstations, and we should start that in our 30s so we don't have to play catch up. And listen, I do my best, but I work really hard to maintain my 10 pounds overweight, my 15 pounds overweight, and it's annoying, but it is what it is. Dopamine decreases, that's mood and emotional response, also your sexuality component. And then oxytocin is actually something that I do give patients for sexual health and libido in a menopausal, perimenopausal state. So not just for uterine contractions. Again, just to regroup, I like to just put the slides up over because one of these will speak to you and you'll remember it. It's about changing in estrogen, progesterone, oxytocin, testosterone, dopamine, and serotonin. These levels matter because that's where we target our therapies if needed. What's interesting, and again, I know this won't surprise you, is that in the United States, the FDA has not approved the use of testosterone in women. Well, our levels go down too. So what those of us that are certified in menopausal care understand is that testosterone at 1/10 of the dose for our male counterparts or somebody that's not in a gender change type of situation should be able to bring our testosterone levels back up to a perimenopausal level, and you actually may feel better. So conversations to have with your providers. Vasomotor symptoms is the hallmark of menopause, but again, all of these other pieces are related, and up to 80, it's probably closer to 90% of women will have some type of fast heat sensation, face flushing, and there's triggers with stress, triggers with caffeine, triggers with alcohol, triggers with certain foods. All of these things can be occurring. Typically, they can be 5 to 7 years. And women who have more hot flashes will have higher cardiovascular risk. It is more severe with surgical and chemical menopause. So for all the patients that we take care of on the floors that are having ovarian removal for whatever reason, or they have BRCA, they will have a much more significant higher complication rate during menopause. I want to also point out, and this is extremely important, that all the research we're doing is from a BIPOC perspective, that women of certain backgrounds, certain genetics, certain dietary changes will have different associations with the symptomatology of vasomotor symptoms. So again, meaning if you have more vasomotor symptoms, you have more complications, more cardiovascular risks. So we really have to be in tune to what's happening from all backgrounds. And you're going to have more fatigue, right? 75% of menopausal women experience fatigue. They have difficulty sleeping. And it's the chicken or the egg. What came first? I got a hot flash. I woke up. I had a hot flash that causes stress. It's very significant. And that's why we have that huge impact on our work productivity. A greater than 6 a day is pretty severe. And there's a lot that can be done to help. We also know that lower health status could be associated also with vasomotor symptoms. And this was a study done about 10 years ago, looking at how long certain women from backgrounds experience vasomotor symptoms, and it's very significant in terms of the differences. So our jobs as educators, clinicians, and researchers is to figure out why and best help in a preparatory way rather than a catch-up. I know I'm going to kind of run through these last slides, so I'm going to give time for questions. So just in general, there are some medications that can help. And for those that lived through the Women's Health Initiative in the 90s, they did everything wrong. They put women that were immediately in their menopausal transition the first year and compared them to women that had been in menopause for over a decade and a half. So the risks of cardiovascular compromise, the risks of breast cancer that they said were higher is all false. So this study undid women's health by 30 years. So 3 decades, we're finally catching up. MHT, menopause hormone therapy, is the gold standard for relief of menopausal vasomotor symptoms, and it can come in various forms. I'm not going to get into the details, but if somebody has a uterus, they have to have progesterone with the estrogen. It could be oral, it could be patches, gels, rings. There also is selective estrogen receptor modulators that can be very good for painful sex and discomfort vaginally, as well as, again, a combination with progesterone is needed if they have a uterus. 75% reduction. Other things that have been shown to help is SSRIs and SNRIs. Again, we talked about don't stop that pre-pregnancy. Well, maybe you don't stop it menopausally either. There are only 2 FDA-approved medications that are non-hormonal for vasomotor treatment in the United States. One is Bristol. Bristol is paroxetine. How many of you have taken care of a patient that's on paroxetine? That medication decreases hot flashes, and they just marketed by a different dose and then are charging women more. The newest one was last May, phenylizetant, which you may see the commercials for Veoza. That is another medication that affects part of the hypothalamus, which is where our temperature regulation is. And then oxybutyn is medication for urinary issues, but it really should not be prescribed. I just left it on there from more of a historical perspective because it affects cognition, so we don't want to do that. These are just the first estradiol is what's in contraceptive pills. And then estradiol itself is a much a lower bioavailability. So you're not comparing apples to apples from that Women's Health Initiative study. It's different. Half-life is different, and it's metabolized in the same way through the liver. There are some red, yellow, and green. So when I'm doing a hormonal consultation or when one of my medicine colleagues is, there are certain things that are hard stops, which we say no to. And really, a lot of that has to do with active blood clots, cardiovascular disease that's significant. And then breast cancer, I just want to put an asterisk because a triple negative may be not the same as a estrogen and progesterone positive. And even for those women, local estrogen vaginally is safe. So when I have my patients suffering from painful sex and vaginal dryness and they've had breast cancer, I have many patients on local estrogen and the bioavailability is very low. and it does not have that same systemic effect. Just from screening, bones, boobs, butt, and beyond, I just want to, in the last few minutes, what should we be telling our patients to do? So they should have a bone density. The US Protective Task Force says 65. I do it much earlier if there's other risk factors, and a calcium vitamin D balance. This is generalizable, but not for every patient. We do recommend a mammogram every year. And for those of us that have higher risk for breast cancer, and this is Breast Cancer Awareness Month, you should also have an MRI that complements, and again, speak with your provider about that. You may see if you go to Northwell Science, the breast arterial calcification score. BI-RADS is what we do for mammography and breast tissue, but you can actually see breast calcifications, which may mean that women is at significant risk for cardiovascular disease, and you're just picking it up on a screening mammogram. So incredible technology and ways to help improve women's health. Colonoscopy 45, and then everybody should wear a sunblock every day, and you should have annual screening. Breast cancer risks if you've had your first menstrual period at a younger age. If you go through menopause at a later age, average age is 51, 52. If you give birth, your first child at 35 or younger, you have a lower risk. And the more you've given birth, you also have a lower risk. If you breastfeed, you have a lower risk as well. So some pros and cons. Exercise is important. And again, women who do drink more have a higher risk of breast cancer. If you are overweight, if you smoke. And regular exercise is helpful. Again, I just want to show you guys some of these pictures in terms of what density is. You can see the picture all the way at the end. It's so dense, it's so bright white. This is what the mammogram looks like. And a relative risk will tell you whether or not you need the additional MRI. Density, you're not going to feel on an exam, and you do have a higher risk of breast cancer if you do have dense breasts. We're using the Trier-Cusack model, which is the fourth. Gale model used to be used a lot. And if you do have a higher risk greater than 20%, it'll come up on your breast imaging results. You'll know it. Making your risk factor has to be personal. Again, we talked about that. And then osteoporosis, kind of in the last few minutes, age, fracture, low BMI, exercise can be preventative, smoking, alcohol, and this whole laundry list of medications. So this is when it has to be done. This is how it's scored. It's scored in such a weird way with the negative values, but the FRAX score is for people to tell you what your risk factor is. Again, all in women's health, we want to assess and decide who needs additional intervention, and this can actually be pulled up on the internet. So you can calculate your own FRAX score, how likely you are to have a major risk. They asked for a book. Dr. Mosconi is incredible. She's doing so much work with cognition and estrogen, and really a pioneer in the field. So this is a great book if you guys are interested in reading and understanding that midlife is not just gynecologic.